Welcome everyone, this is Yasser Wasifi from Learn Dental Series. In the coming episodes, we will discuss a new topic which is indirect two-scalared restorations in a trial to perfectly or mastering the aesthetic reproduction and mastering reproduction of tooth contact and contour and also anatomy. Let me declare that I don't receive fees, compensation, or royalties from the sales of any of the products shown or discussed. Also, this presentation is not sponsored by any company, agency, or organization and is only prepared for educational purpose. This presentation is copyright protected and could not be transmitted by any means unless you have a written permission from the author. By the end of this presentation, our expected outcome is you should be able or you are expected to be able to differentiate between direct and indirect technique, identify advantages and disadvantages of indirect two-scalared restoration, identify indications and contraindications of indirect two-scalared restoration, and how to link between these indications and contraindications and the material advantage and disadvantage, where the material should be used whenever it is advantageous and could be contraindicated whenever its disadvantages could not be controlled. Also, we will illustrate the principles of cavity preparation for indirect two-scalared restoration and differentiate between cavity preparation for indirect metallic and indirect two-scalared restoration. And finally, we will identify and discuss different techniques and types of indirect two-scalared restorations. Let us start with part 1, which clarifies the difference between indirect and direct restorative technique. In this part, we will discuss the difference or indirect versus direct restorative technique in terms of introduction, advantage and disadvantage, indications and contraindications, and finally the difference in cavity preparation. As introduction, it is known that for everyone in restorative fields that the available restorations could be classified according to the nature of restorative material and the technique of construction. According to the nature of restorative material, our available restorative materials are either metallic or non-metallic. Always metallic provides strength while non-metallics are introduced in order to provide aesthetics. But nowadays, the new non-metallic systems of composite resin and ceramics are providing strengths equal to and sometimes higher than the available metallic restorations. Not the available metals in general, but the available metallic restorations. According to the technique of construction, our material are classified or our restorations are classified into direct and indirect restorations. Direct restorations, as discussed many times in previous episodes, are restorations where the material are applied into a prepared cavity intraorally while it is in its plastic phase for a limited working time that allows its manipulation intraorally, backing it condensation intraorally, sometimes under force, condensation force like that of amalgam, and this will leave the material to set, and the working and setting time will be consumed inside your prepared cavity intraoral, and the material will get the shape of the cavity as it is, and this will increase adaptation of the material to cavity walls and margins, and at the same time you could design a cavity with any mechanical undercuts that provides maximum axial retention. But for indirect restoration means that the material is constructed extraorally outside the oral cavity and comes in a form of completely set material, hard piece of restorative work that will be inserted into the cavity, placed into the prepared cavity, then cemented into place to restore the tooth function and occlusion. The difference is one is shaped inside the cavity and solidifies or set inside your cavity, and you are limited by a working time. Here, the restoration comes absolutely solidified or absolutely set and then cemented into place. The difference in between is that direct restoration, you are limited with the availability of working time and sitting time of the material itself inside the oral cavity, while the indirect, you are limited with the working time or sitting time of the cement used to seat the material or to adhere the material to cavity walls and margins. In the first one, which is direct, the material already set inside the cavity. In certain cases like that of amalgam restoration, under condensation force that increases the adaptation rate, and at the same time the cavity could be supplied with mechanical undercuts to add axial retention. For indirect one, the cavity should not have any undercut. Okay, that's why the axial retention is to somewhat questionable. Okay, we will try during cavity preparation just to increase the axial retention by a mean or another. Okay, and the material will lack adaptation. At the same time, the construction or manipulation will be much easier, especially if you have a lingual damage or if you have to restore properly tooth function and occlusion. That's why when we consider direct technique and try to conclude advantages and disadvantages of the technique, for direct technique it will provide maximum adaptation as most of the materials are applied under condensation force while it is still unset or while it is still in the plastic form. But this is not applicable for composite resin material because it will show at the first a great flow, a great wetting, and a great adaptation to cavity walls and margins, which will be lost immediately during polymerization due to polymerization shrinkage of composite resin, which takes place inside the cavity and impaired adaptation. Also, direct restorations provide retention as you could prepare your cavity with mechanical undercut. One of the most important advantages that it is finished in one sitting. Okay, maximum two if you would like to place a rest restoration or temporary restoration for to sedate your bulb if you would like to do that or if the case is in need for that. Okay, but what is the disadvantages of direct technique? You are limited with a working time and sitting time of the material. That's why needs a great skill of operator and cooperative patient in a trial to finish within this working time to get the best result of your restorative treatment. Okay. Also, could not restore the anatomical form of and occlusal relationship exactly or accurately, especially if the tooth having a missed lingual part which or large cavity which will impair to reproduce the lingual occlusion. Here you are depending on your accuracy and your skills in applying matrix to reshape or reproduce your missed part. Okay. Also here it is not suitable for cavities extended deep subgingival because cavities extended deep subgingival needs much more restorative procedures and maybe you are in need for periodontal procedures in the form of crown lengthening and it will be much more complicated even if it is not violating the biological width as we mentioned before in many episodes, but at least you are in need to add tissue retraction cord, matrix, and how you could control the gingival fluid, how you could control the bleeding in order to condense your material or apply bonding procedures if it is a direct composite resin restoration, okay, and how you could make sure that you are following the instructions and following a perfect performance of your procedures in this subgingival area. And if all of these are not factors related to you as a skillful operator, but what about the light penetration to this area, okay, to ensure proper polymerization? This is for direct technique. For indirect technique, in controversy to this, there is a decreased adaptation because already the material, okay, is not applied in its plastic phase, it is applied in its completely solidified form, okay. That's why it will not take the exact shape and not applied under force, okay? And you are in need actually to have a minimal gap to seat the restoration into place, okay? That's why it lacks adaptation, except that for composite resin, because all polymerization shrinkage takes place outside the oral cavity, outside your prepared cavity, and could be compensated after that by using adhesive resin cement. And the total shrinkage of adhesive resin cement will be minimal because you are using actually quantitatively a very minimal amount. That's why you still have a chance without adding too much steps or too much manipulative steps to compensate for polymerization shrinkage. This is the case only for indirect two-scalared restorative materials, okay? Also here we have a decreased retention, especially axial one, because the cavity is not designed to have axial undercuts that provides maximum axial retention. Also, this is not the case truly, or not to that extent important in case of indirect two-scalared restoration, because already we used adhesive resin cement that shows satisfactory retention, especially if you are following the manufacturer instructions exactly, okay? But still, the restorative procedure needs much more visits, more than one visit, and in between visits there may be a change in your cavity configuration due to fracture of a weak area, or there may be a bulbal affection due to solubility of temporary restoration, which should be considered when you design your cavity and when you instruct your patient what could he behave in between the two visits you are in need. But it doesn't need great skill of the operator and the cooperation of the patient, unless if you consider the cementation procedures, okay? But otherwise, your role is finished in most of cases just for accuracy of impression. The patient not in need to open his mouth too much for application of material or for packing the cavity with composite resin increment by increment, okay? That's why it doesn't need too much great skill for the operator, even when you are shaping the occlusal anatomy or proximal contact and contour. You have a chance for proper reproduction of anatomical form and occlusal relationship because you are working outside. It's similar to that of cast mold restoration. You could mount it in a cast and you could check the occlusion from all sides and contact relationships from all sides. It is suitable for cavities extended deep subgingival, but is still very deep or extremely deep subgingival is not a favorable condition for indirect two-scalared restoration because of the cementation procedure. Don't forget that you are still using adhesive resin cement, which should follow the same procedures and the same precautions for applying bonding agent to dentine. That's why still the condition is critical. But what is more important is the convenience and the accuracy of color reproduction. You could correct the color, you could correct the shade, you could shape the tooth, reproduce the shade, okay, in incremental packing. Your systems for indirect restoration and now for direct restoration also having special shades for dentine, special shades for enamel. You could add characterization stains. All of these facilities enables you for much more convenient layering of your composite resin if you are using composite or ceramics that could be used, or actually it is the firstly introduced indirect two-scalared restoration before introducing composite to this field, okay? You could layer it, okay, by an easier technique, even if it is not a uniform layer, but you could add characterization that matching the exact aesthetic reproduction of your tooth. The technique sensitivity of such cases is only limited to cementation procedure. Otherwise, it is not as technique sensitive as direct composite resin restoration. That's why when we are discussing advantages and disadvantages, just I would like to remember you that most of advantages of indirect to colored restoration, either due to the technique itself as being indirect, which adds convenience of manipulation and the ability to reproduce color and shade exactly, the material as being aesthetic, or still you have adhesive property, okay, by using adhesive resin cement that adds much more reinforcement of remaining tooth structure than non-adhesive cement. The first advantage is that you are selecting a material with better physical properties. Indirect tooth colored restoration or indirect restoration of in general having a better physical properties than direct one. When you are comparing gold as indirect restoration to amalgam, both are metallic restorations, you should mention that gold is a high strength property material in all types of strengths. That's why it could be used in very thin sections. There is no limitations of your bulks that should be at least 2 millimeters as that for amalgam. Otherwise, it will fracture under occlusal tensile component of occlusal loading force and could be finished into thin margins. That's why you are supplying your cavity with bevel to be able or allowing room to burnish gold and protect enamel margins. Okay, when you are comparing indirect tooth colored restorations with direct tooth colored restoration, number one, there is a great availability, and the first indirect tooth colored restoration was ceramics, and ceramics are much more biologically compatible, much more aesthetic with great translucency and varieties of shades, okay, compared to direct composite. Even if you compared direct versus indirect composite, indirect composite is processed outside the oral cavity, and this adds too many advantages. One of them is the degree of conversion of your composite due to maximum polymerization that adds a material, or the final restoration will show maximum conversion. That means that you finished your polymerization reaction till the end. You are not affected by the depth of light cure and the energy of your light. You could use light curing, you could use pressure, you could use heat, which are not available to be used intraorally. You have only intraorally, either it is self-chemically initiated reaction or photo-initiated reaction. Okay, those are the two options, the only two options you could have when you are using direct composite resin restoration. And that's why the material is suffering from wear, which is dependent on the degree of polymerization and degree of conversion. At the same time, the modulus of elasticity and the stiffness and the strength of the material, all of these are affected by degree of conversion. While when you are using indirect composite or processing your composite resin restorative material indirectly, you have the availability to cure it with light, with pressure, with heat, or with all of them, as this is increases the degree of conversion, which in terms also increases the stiffness of the material, the strength of the material, and the wear resistance of the material. Also, the total volumetric polymerization shrinkage increased, but this is not important for me because already it happens outside the oral cavity. Then comes the question, what is the degree of conversion you repeatedly mentioned at? Let us view this video, and this video not discussing the degree of conversion of composite resin, but it is for polyethylene, which is also a resin-based material undergoing polymerization reaction. It is similar, exactly the same to that of composite resin. It's the same idea of all polymers. Okay, let us start with what is polymerization process of polyethylene. This is the molecule of polyethylene, two carbon atoms with double bond. Okay, this is ethylene. Okay, please note that the two carbon atoms, each one is bonded with 4 bonds, 2 with hydrogen and 2 with the neighboring carbon atoms. Okay, what happens? This is the peroxide initiator. This peroxide initiator is broken down by either heat or light or pressure, whatever the mode of activation. Then this molecule initiator is easily split, okay, and now it has a free radicals that takes one, as you could see, of the carbon atoms, okay, bond, okay, from the other one. The other one is trying to merge by this bond to another molecule, and this is, as you could note that, okay, just to be stabilized with 4 bonds, okay, the carbon atom, and this is what is called propagation. Then you are now transforming the bond between 2 carbon atoms, okay, by double bond into a single bond, until you have a chain of a polymer that joined or linked to another polymer chain, okay, by the free end, and both of them are closed from the other ends with the initiator. This is what is called termination. Then, with continuous decomposition of your initiator due to excessive and much more energy for going to break down it and releasing much more free radicals, okay, what happens is a cross-linking. That's why you are, remember that you are consuming all the free radicals of the initiator, okay? This initiator is continuously broken down as the activation is continuous. That's why it will attract one of the hydrogen, okay, to be stable, and your carbon atom have no other way is to bond with another chain of polymer, okay? This is called cross-linking, and accordingly you could note how much your composite or your polymer is reduced in size. This is the polymerization shrinkage, and according to the amount of cross-linking, the flexibility of your and the stability of your polymer chains is determined, and accordingly this is the difference in modulus of elasticity between a material and another, and both of them are polyethylene. Okay, polyethylene is used in a stretch ceiling wrap, okay, used in household use, okay, just for wrapping any plates, for wrapping in groceries, okay, your stuff, okay, and also it is used in a much more harder form than this ceiling wrap, okay, in manufacturing athletic shoes, especially the ties, okay, up to the huge pipes that transmits water to a city, okay, or to drain water from a city, okay. All of these are polyethylene. What is the difference? The difference is flexibility and modulus of elasticity, and the difference in the strength, okay. This is affected by to how much you are cross-linking your material. It is the same for composite exactly, okay. The degree of conversion of composite resin is defined as the percentage of carbon double bonds that is converted into a single bond. If you stop your statement at this word, okay, is the percentage of carbon double bond that is transmitted into carbon single bond. It seems to be weaker, okay. Double bond is much stronger than single bond, but actually you are transforming the relation between 2 carbon atoms from double bond to single bond because you are using these extra bonds to be transformed from a monomer to a polymer, and for cross-linking. What is meant by carbon double bond? Carbon double bond, it's a monomer molecule. Carbon single bond, you are already consumed one of these bonds to bond with another monomer molecule until complete propagation happens and determination happens. Then between the linear polymer, you are again converting double bonds to single bond by cross-linking your material, okay. This is an important parameter in determining the physical, mechanical, and biological properties of composite. Biological properties, yes, because all your material are consuming its free radicals and will not leach out any of its constituents due to its maximum polymerization and maximum higher degree of conversion. Okay, that's why it becomes much more biologically compatible than direct composite. Okay, and you could note that the higher the degree of conversion, the better will be the final properties of the material of composite: stiffness, modulus of elasticity, strength, wear resistance, but also, as you note in the video, the cross-linking means that you are approximating the molecules to each other. Okay, it's a cross-tying procedure. Okay, it's a cross-linking procedure in expense of you are collimating monomers into polymer. All of these results in maximum volumetric polymerization shrinkage. Then we could conclude that by using composite resin in a way or another to be indirectly processed, that means that you are consuming much more free radicals. You will not have free radicals. Please remember this, okay, because in the last episode, it will affect the bond between the fitting surface of your composite and the resin cement, because already most of the free radicals, almost all, are consumed during your polymerization procedure. This is number one. The degree of conversion is higher, means that your polymerization reaction is as maximum as possible, and the cross-linking is as maximum as possible. That means that already you will have a volumetric shrinkage as maximum as possible. Okay, but being indirectly processed, this will not be changed into inside the cavities. This will be compensated by the resin cement. Okay, at the same time, wear resistance is better, translucency is better, biological compatibility will be better. The material in general, physically, mechanically, and biologically will be better. This is the first advantage of indirectly processed aesthetic restoration. You get a material with better properties. Either you are using ceramic, which is better in aesthetic and strength properties and biological compatibility than composite. Even if you use composite resin, indirectly processed is much more higher in its properties due to increased degree of conversion than that of direct composite resin. Then, as a sequence of this, okay, there will be increased resistance to abrasion and wear, because ceramics are already having a great resistance to abrasion and wear. Okay, but please take care of this, because if the patient having any abnormal eccentric occlusal habits or parafunctional habits, okay, due to increased hardness of the ceramic material, it may affect the opposing natural enamel. Okay, this should be considered for your indications and contraindications. Indirectly processed composite, just now we are discussing the degree of conversion that leads to higher wear resistance than direct one. Then comes what is called reduced polymerization shrinkage stresses. Okay, what is polymerization shrinkage stresses? Because when you apply a bulk of composite resin, when it shrinks towards the light or towards the ore, it produces an attraction force, okay, which is called polymerization shrinkage stresses. Okay, this is related to how much you are cross-linking the material. Okay, the increased cross-linking, the more will be the polymerization shrinkage stresses. But now I'm discussing it as an advantage, reduced polymerization shrinkage stresses. Actually, the total polymerization shrinkage stresses of composite resin, which is processed indirectly, is much more or far higher than that directly processed, because it is affected by the degree of conversion. The degree of conversion for directly processed composite is affected by the light depths, okay, and the power of your device. But here you are using light, pressure, heat, one of them in extensive power, or you may use systems, other systems may use all of them. Then it's something wondering why you mentioned that reduce the polymerization shrinkage stress. Actually, because this will not happen intraorally. In fact, if you are measuring it in numbers, okay, trying to quantify them, okay, then the total polymerization shrinkage stresses is far higher. But the advantage is this will not happen, will not affect your tooth structure, okay, leading to marginal voids or leading to marginal gaps or leading to any gap formation at tooth restoration interface. The only thing is you are applying resin cement, and volumetrically, as a quantity based, what are the quantity of your resin based cement to be used? It is a minimal one that will not allow too much production of polymerization shrinkage stress. To understand the effect, let us discuss how the effect of polymerization shrinkage stresses of direct composite and what is how it is produced to know this advantage or to discuss this advantage in full details. This is a piece of composite. The shrinkage will be always towards the side of the center of initiation. If it is left for a free polymerization, okay, then it will be free shrinkage, okay, and it will be towards the center. Then your molecules, monomer molecules, will be accumulated towards the center where the major bulk of initiator decomposition is in the center, and this is true for chemically activated composite, okay, and it will be directed with its stresses directed toward to the center. But effective shrinkage, when you are applying an increment of photo-initiated or photopolymerized composite resin, this increment will wet your wall. Your wall, which cavity wall, having a temperature, body temperature, which activates initiation of your composite, and also your bonding agent applied, which appears as the dark line above the yellow tooth structure, the yellow rectangle that represents the tooth structure, okay? This still having a free radicals that are ready for reaction, okay? That's why the effective shrinkage will be towards the cavity wall, okay? And that's why it was discussed before that the C factors, you should have a maximum free surface, okay, to let the composite compensate its shrinkage from the free surface and to be directed toward the wall, where your cavity wall having a body temperature, having much more than that of outside atmosphere, okay, of your room. At the same time, your free radicals from the bonding agent wetting your cavity walls. Then, before polymerization, okay, once you are applying your increment, okay, it is like that before polymerization, and after you are getting your light and starting polymerization in the initial phase, which is the material is still in the gel phase, okay, and not fully polymerized, still could undergo deformation and compensation of this deformation, okay. This is the pre-gel phase. The material shrank toward its center, okay, and still much more adheres, okay, to the cavity walls, and the material will be much more directed to the area, or your shrinkage will be directed to the area of first initiation, which is the cavity walls, okay, and your shrinkage could be compensated from the center. But when the material could not undergo much more deformation and it passes the gel point, you have two possibilities, okay. The material now, okay, adheres to the cavity wall and trying to shrink towards the light, okay, because the light now is the area of the most active initiation. Okay, it will try just to shrink. When it is trying to shrink and starting to produce shrinkage stresses at this area, you have one of two possibilities. Either your bond strength is higher than that of shrinkage stresses, which is determined by 17 megapascal, okay, average when we discussed bonding agents before in previous episodes, okay, then your bond strength exceeds 17 megapascal, then your shrinkage stresses will take the material which is bonded firmly with more than 17 megapascal with tooth structure, okay, and the tooth structure will deflect a little bit towards the direction of light. As you could note in our schematic diagram, okay, the material is trying to shrink towards the center, okay, or towards the direction of light, and the bond strength is higher than or exceed the polymerization shrinkage stresses, then it will result that deflection of tooth surface, okay, and this will depend upon the strength of your cusp. Is it a weak cusp or undermined cusp? Okay, this is possibility number one. Possibility number two, your bond strength is weaker than the stresses produced. And at this time, regardless your tooth structure is weak or strong, okay, then a debonding will happen at the margin. Okay, that's why you should apply your composite incrementally, okay, not only for the depth of light cure, which should be 2 millimeter, okay, at least, but it is better to be lesser than 2 millimeters, because this total polymerization shrinkage stresses relate to the total volume or the total amount, okay, of the increment of your material. If you apply a smaller increment and you are trying to let the free surface of your increment is higher than the bonded surface by applying increment by increment, this all shrinkage stresses will be minimal than the bond strength, okay. You will produce a proper bonded surface, no surface gap, no marginal gap will be produced, okay, no deflection on your cusps, and all of these sequelae of shrinkage stresses. We could note that this one, okay, is clinically showing the cracks produced when your cusp is weak and your bond is strong, okay, and you are curing your composite with higher energy, okay, then a micro cracks and the cusp deflection of these micro cracks, okay, appears. Take this step. When you are curing a piece of composite, okay, or increment of composite, and the patient is feeling a tightening pain with light cure, and when you stop, it is relieved. Previously, it was thought that this is due to heat generation of tungsten halogen light or previous old-fashioned devices for light curing unit. But when they studied the shrinkage stresses, okay, that means that a cusp deflection happens. That's why the patient is feeling a tightening pain or a squeezing pain, okay. What does it mean? This means that, okay, number one, what's good is your bonding strength is higher than the shrinkage stresses, and you are following the instructions and you are performing a high performance bonding between your composite and the tooth structure. But that means that you have either a weak wall or a weak cusp, or the increment of is large, or the energy is high, okay. That's why in such a condition, okay, you should use a smaller increment of your composite, okay. You couldn't change the cavity wall, okay. You couldn't re-strengthen it, already it is cut, okay. But this is an indication that you should use a smaller increment with a lower energy output of your device, but you could increase your time, okay, for application. This is to avoid this crazy lines and cusp deflection, because it is unnoticeable at this time, and maybe your patient came to you with restoration in place, but the cusp is broken, especially as you could note the crazy lines at the base of the cusp. Other possibility is the bonding procedure is not to that extent perfect, and your shrinkage stresses are higher than the bond strength, and a debonding occurs or a fracture of enamel margin. When you are finishing your composite, you could note, okay, a white line at the margin that indicates debonding. At this situation, you should restore your tooth, remove this composite. Already you have a gap that could be noticed as a white line immediately after when you are finishing your composite. You should repeat your composite, restore your tooth, and follow the instructions in bonding agents, because this is denotes that your bonding is questionable. As indirectly processed composite resin restoration have a higher degree of conversion, the polymerization shrinkage will be much more higher in volume and in stresses, but as being fabricated outside the prepared cavity, the resultant stresses inside the cavity will be of no value, because only the shrinkage stresses of your resin cement will take place. All of these shrinkage stresses for indirect restoration, which is much more higher or far higher than that of directly processed composite, okay, is of no clinical value because already takes place outside your cavity. Then, from the advantages of indirect tooth-color restoration, still you have the option of strengthening the remaining tooth structure, because still you are applying the bonding procedures that cross-tying the weak tooth structure with the strong restoration or the strong neighboring structure, because you are using the same bonding procedures, okay, for applying adhesive resin cement. Okay, as being indirect restoration, you have a more precise control in reproduction of contacts and contours as all indirect restorations. Okay, because there is a great accessibility when you mount your upper and lower casts, okay, and on an articulator, and you could note the contact relationship, the occlusal relationship, how to reproduce it exactly, okay. And also, as being indirect, you have much more auxiliary support. You could use much more devices or equipment, okay, that have a higher output energy for curing your composite, okay, that could not be applied clinically intraorally, okay. And at the same time, you could save your patient time and your time. Your role could stop at the level of impression, and all the other procedures are the responsibility of your lab technician. And then come your role again just only for cementing your restorative piece. That's why you have increased auxiliary support. Let me tell you something. You couldn't apply clinically ceramic restoration in a direct way, because we don't have any furnace, okay, to be used intraoral, okay. This is an example for auxiliary support. The devices and machines used for and equipment like curing unit, pressure unit, that is used to increase the degree of conversion of your composite could not be used intraoral, okay. This is another advantage. Disadvantages is increased cost and time, because the material is expensive, the facilities you are in need is expensive, even the adhesive resin cement is also much more expensive than regular cement, okay. Technique sensitivity is still the material is or still the technique is sensitive to moisture, especially for applying adhesive resin cement, because the bonding procedure, you will note that when we reach to this topic, okay, related to the cementation, that you are applying all the adhesive steps twice. You are applying adhesive steps for the fitting surface, management of the fitting surface of your inlay, and the regular management of your or treatment of your cavity wall. Okay. Another problem is the brittleness of ceramics. Okay. The material is highly brittle. That's why during dry-in and cementation, you may repeat all the procedures again, okay, or may ask your lab to produce another one because of the material is fragile and already broken during your dry-in, okay. Indications and contraindications are simple procedures indicated mainly if you are in need for aesthetic, like that you are in need to reproduce aesthetic of large posterior cavities, occlusomesial cavity, okay, class 1 or class 2, okay, and mesial surfaces of first molar are now considered as to be within the aesthetic zone, okay, and you need to reproduce aesthetic and restore this proper contact. It is better to be replaced, especially if you have an extensively damaged cusps like these cases, okay. Large cavities or previously failed restorations, okay. In these cavities, you are in need for adhesive bonding to reinforce the remaining tooth structure. You are in need to recontour these extensively damaged tooth to develop proper contact and contours, okay. At the same time, you are a much more durable material in to service well with these extensively damaged tooth, okay. That's why it is indicated for large cavities or previously failed restoration, like this case, okay, with previously failed, inadequately adapted, or improper bonding with the tooth structure for those premolars. Okay, the first premolar showing extensive wear, the second premolar showing open margins, and you have a recurrent caries and damaged margin of amalgam. Okay, then the operator removing these restorations. Okay, he is in need to reinforce the remaining tooth structure by bonded restoration to minimize the damage. At the same time, he needs aesthetic material and in need to reproduce contact contours and anatomy exactly. This is the most suitable restoration at this time. Another case of damaged margins are all around amalgam restoration. When the operator removes the amalgam, he discovered those are the remaining tooth structure. At this time, if he is going to restore it with cast metallic restoration, he is in need to completely remove the buccal cusp, the lingual cusp of molar, okay. If he is intended to go for direct composite, then there will be a great difficulty to reproduce the lingual anatomy and the contact relationship and also the reproduction of occlusion, okay. That's why the operator decide to go to indicate the case for indirect tooth colored restoration, which provides much more accessibility in reproducing contact contour anatomy and at the same time preserving the remaining tooth structure, and this is the final case. Contraindicated in patients with heavy occlusal stresses because of the ceramics have higher hardness that may wear the opposing natural dentition, okay. And especially if the patient having any abnormal habits like bruxism or clenching, and composite is still suffering from wear, okay. If although it is indirectly processed, but it is undergoing wear, okay. Inability to maintain dry operative field like last molar tooth because still you are in need for proper isolation for cementation with adhesive resin cement. Extremely deep subgingival preparations, still you will not have enough enamel at this area for great performance and for proper application of bonding procedure, okay, along the gingival margins of the proximal box. And even if you have enamel at this margin, okay, your bonding procedure will be questionable. This is the case of patient with severely abnormal or heavy occlusal stresses. Those are the references I had used in preparing this episode and this presentation. If you would like to have much more knowledge about this topic, okay, including it's about 16 article, okay, and those are the textbooks I used in preparing also this presentation. Finally, feel free to ask me at any time, as your questions are welcomed. You could ask me or add your inquiry in any comment by commenting to this video. Please don't forget to like this video and subscribe to my channel, okay, and activate notification to get all the new updates and all the new episodes. Those are my contact info, and finally I would like to thank you for assigning this time to listen to me. Please don't forget to like, subscribe and activate notification of my channel. Thank you. Yasser Al-Wasif.